Relapsing fever is an infection characterized by episodes of high fever and chills and headache and muscle pain and nausea that recur every week or 10 days for several months. The first form of disease is loss-borne relapsing fever transmitted through the bites of lice. Loss-borne relapsing fever occurs in epidemics amid poor living conditions, famine and war in the developing world. Mortality rate is 1% with treatment, 30–70% without treatment. Poor prognostic signs include severe jaundice, severe change of mental status, severe bleeding, and prolonged QT interval and ECG. Disease is currently prevalent in Ethiopia and Sudan. At the present time, it is reported from the countries of the Middle East, North Africa, Southeast Asia, and South America. It's caused by Borrelia recurrentis, certain bacteria in genus Borrelia. The source of infection is diseased human during the fever period, but the infection can probably be transmitted during apyrexia as well. The infection transmitters are body lice, less frequently head lice. When a louse sucks blood of the patient, it becomes contagious in 5–7 days and remains so for 28 days. Humans are infected by rubbing a crushed louse or its fragments into injured skin or the eye mucosa. Borrelia gain entry through damaged skin and eye mucosa, propagate in the blood, in the internal organs and the central nervous system. Part of the microorganisms are destroyed to release endotoxin. Accumulation of Borrelia and the toxin in the blood causes fever, headache, and myalgia. The endotoxin causes lesion of the vessels and upsets their permeability. Hemorrhagic infarcts and necrosis develop in the liver and spleen, and the symptom of involvement of central nervous system develop. By the end of the attack, antibodies are formed that destroy Borrelia. Subsequent relapses of the fever are caused by Borrelia that survive in the bone marrow, the internal organs, and the central nervous system to give a new race of the microorganisms that differ in their antigen structure. The incubation period is usually 7–8 days, but it can vary from 3 to 15 days. The disease is characterized by alternation of fever and apyrexia periods. The disease begins suddenly and acutely with a shaking chill, which is followed by fever, headache, and vomiting. The body temperature rises to 39 and higher within 1–2 hours. The maximum body temperature 40–41 is seen during the second and third days of the disease. Severe headache is supervened by severe muscular pain, mainly in the calves. Pain can be sensed by the course of the nerves and in the joints. The patient is forced to bed on the very first day of the disease. The skin is dry, the tongue is coated and moist. Appetite is lost, dyspepsia is frequent. The spleen is enlarged on the second day of fever, and pain develops in the left hypochondrium. In 3–4 days, the sclera and the skin become ecteric. The hepatic enlargement becomes more pronounced. Cardiovascular failure is possible. Some patients develop the Roselius petechial and macular rash on the 4th or 5th day of the disease. The rash disappears in a few hours. Nosebleeds are possible because of increased permeability of the capillaries and mucosa and decreased quantity of thrombocytes. Leukocytosis with neutrophilic shift to the left and moderate hyperchromic anemia develop from the first days of the disease. During the periods of apyrexia, leukocytosis is followed by leukopenia, while neutrophiliosis by lymphocytosis and increased number of plasma cells. Eosinophilia develops by the end of the disease. The first paroxysm lasts 5–7 days and ends critically. Normalization of body temperature is attended by profuse sweating. The patient condition improves rapidly in 6-9 afebrile days. Another attack of the disease begins. All symptoms of the first attack are repeated. The second attack lasts 3-5 days. Each next relapse is shorter than the previous one, while the apyrexia period on the contemporary becomes successively longer. In most cases, the course of the disease comprises several such relapses. Nosebleeds are possible. Diffuse nephritis is possible. Splenic infarction. The diagnosis of relapsing fever is simple during the fever period. It's established on the basis of clinical, laboratory and epidemiologic findings. A fingertip blood specimen is sent to the laboratory in the form of 2 thin and 2 thick smears on glass slides. Blood specimens should be taken at the height of the relapse. During the afebrile period, when Borrelia are scant in the blood of the patient, the specimen is centrifuged and smears are prepared from concentrated sediment. The complement fixation test is also used. Treatment. Antibiotics are used: penicillin, tetracycline or chloramphenicol. Prevention and control. Patient with relapsing fever should be taken to an infectious hospital for isolation during the entire fever period and for 20 days after termination of an attack. Measures against pediculosis should be taken. Endemic relapsing fever. Relapsing fever is a disease characterized by relapsing or recurring episodes of fever, often accompanied by headache, muscle and joint aches and nausea. The second form of disease is tick-borne relapsing fever, transmitted through the bites of ticks. Tick-borne relapsing fever is found primarily in Africa, Spain, Saudi Arabia, Asia, and the USA and Canada. Tick-borne relapsing fever is caused by various species of Borrelia. The source of infection are rodents and other animals, and also diseased humans. Natural needi of tick-borne borreliosis are also known. The reservoir and the transmitters of infection are ticks, which inhabit the cracks of clay-lined houses in sheds and trodden holes. After a tick bites an infected animal or human, it remains contagious for its entire life and transmits infection to its posterity. In natural needi, the infection circulates between ticks and wild mammalians, rats, voles, hedgehogs, badgers, and birds. In populated places, domestic animals and humans become incorporated into the circulation of infections. Humans are infected by tick bites through its saliva. Immunity is maintained in endemic foci due to repeated tick bites. The morbidity increases in spring and autumn due to increased activity of the transmitter. Pathogenesis is the same as in epidemic relapsing fever. The incubation period is 11-12 days with extremes of 5 and 20 days. The onset of the disease is usually acute. The patient develops chills, the body temperature rises rapidly to 39-40 and higher. The patient complains of headache and pain in the calves. The patient is excited. Delirium and confusion are not uncommon. Pulse is fast. The skin is slightly icteric. The spleen is enlarged insignificantly. A cherry-colored papilla is formed at site of tick bite. The attack lasts 2-6 days and ends in crisis, but another relapse begins after several afebrile days. Each next attack is shorter, while periods of apyrexia become on the contrary longer. From 6 to 12 relapses usually occur during the disease, but their number can be 15-16, and the overall length to the disease is thus 1-2 months. Signs of chromic anemia, leukocytosis, monocytosis, and eosinopenia can be seen. ESR is accelerated. The diagnosis is based on the specific clinical, laboratory, and epidemiologic findings. Laboratory studies include examination of thin and thick smears. Treatment: doxycycline, penicillin, erythromycin, chloramphenicol, and ceftriaxone are effective. Prevention and control. Control of rodents and transmitter of infection is the main preventive measure. Rodent-proof buildings in infested areas and remove rodent nesting material from walls, ceiling, and floors. Post-exposure treatment with doxycycline appears to be effective. The skin should be inspected and ticks removed. Lyme disease. Lyme disease or Lyme borreliosis is an emerging infectious disease caused by Borrelia. Left untreated, later symptoms may involve the joints, heart, and central nervous system. Delayed or inadequate treatment can lead to the more serious symptoms, which can be disabling and difficult to treat. Lyme disease is a biosafety level 2 disease. Lyme disease is the most common tick-borne disease in the northern hemisphere in North America and Europe. Borrelia burgdorferi sensu stricto is the main cause of Lyme disease in the United States, whereas Borrelia avzeli and Borrelia garini cause most European cases. Deer ticks, which feed on the blood of animals and humans, can harbor the bacteria and spread it when feeding. Borrelia is transmitted to humans by the bite of infected ticks belonging to a few species of the genus Ixodes, hard ticks. Early symptoms may include fever, headache, fatigue, depression, and characteristic circular skin rash called erythema migrans. Lyme disease is medically described at 3 phases as early localized disease with skin inflammation, early disseminated disease with heart and nervous system involvement including pulse, paresis, and meningitis, and late disease featuring motor and sensory nerve damage and brain inflammation as well as arthritis. The incubation period from infection to the onset of symptoms is usually 1 to 2 weeks, but can be much shorter or much longer, months to years. Asymptomatic infection exists. The classic sign of early local infection with Lyme disease is a circular, outwardly expanding rash called erythema chronicum migrans, which occurs at the site of the tick bite 3 to 30 days after the tick bite. The rash is red and may be warm, but is generally painless. Classically, the innermost portion remains dark red and becomes indurated. The outer edge remains red and the portion in between clears, giving the appearance of a bullseye. However, partial clearing is uncommon and the bullseye pattern more often involves central redness. Patient can also experience flu-like symptoms such as headache, muscle soreness, fever, and malaise. The redness resolves without treatment in about a month. Weeks to months after the initial redness of the skin, the bacteria and their effects spread throughout the body. Subsequently, disease in the joints, heart, and nervous system can occur. The later phases of Lyme disease can affect the heart, causing inflammation of the heart muscle. This can result in abnormal heart rhythms and heart failure. The nervous system can develop facial muscle paralysis, abnormal sensation due to disease of peripheral nerves, meningitis, and confusion. Arthritis or inflammation in joints begins with swelling, stiffness, and pain. Usually, only one or few joints become affected, most commonly the knees. The arthritis of Lyme disease can look like many other types of inflammatory arthritis and can become chronic. After several months, untreated or inadequately treated patient may go on to develop severe and chronic symptoms that affect many parts of the body, including the brain, nerves, eyes, joints, and heart. Many disabling symptoms can occur, including permanent paraplegia in the most extreme cases. Diagnosis is made on signs and symptoms, a history of possible exposure to infected black-legged ticks. Laboratory blood tests are helpful if used correctly and performed to this validated method. Most cases of Lyme disease are curable with antibiotics. The type of antibiotic depends on the stage of the disease, early or late, and what areas of the body are affected. Early illness is usually treated with medication taken by mouth, for example doxycycline, amoxicillin, or cefuroxime acetyl. Later illness such as nervous system disease might require intravenous drugs, examples are ceftriaxone or penicillin G. For relief of symptoms, pain-relieving medicine might be added. Prevention. Be aware of ticks in high-risk areas like shady, moist ground cover or areas with tall grass, brush, shrubs, and low tree branches. Lawns and gardens may harbor ticks too, especially at the edges of woods and forests and around old stone walls. Areas where deer and mice, the primary host of the ticks, thrive.